Warning, this podcast does not introduce any new information outside the Foundation's curriculum. We will also be discussing some sensitive material in this podcast for some listeners and viewers, so listener discretion is advised.
Hey there, listeners. Welcome to a new episode of Real Doctors, Real Friends, the official podcast of Foundations of Medicine. I'm your host, Shereen, along with my partner in medical education, Roshan.
Hey, everyone.
I've been reflecting a great deal on societal and health challenges in our community. Something that I find heartbreaking and difficult to understand in equal measure is substance use disorder. Do you have patients that are struggling with substance use disorder?
Absolutely. I have a broad general practice in family medicine, and definitely there's substance use disorder. And I would say it's a spectrum, which is what's important. We have mild, moderate, severe. We have individuals suffering from substance use disorder related to alcohol, related to opioids, related to other drugs, hard drugs such as cocaine or heroin. And it truly is a spectrum because really everyone is different.
Yeah. And people in the throes of addiction are suffering tremendously. That suffering is physical, psychological, as well as financial and social. But the drive to use substances persists and even escalates.
As a clinician, a scientist, or a friend or family member, it can be challenging to understand why conventional intervention strategies and treatment programs are not always successful, or even what factors drive relapse. And I think what's incredibly frustrating for us as physicians, especially as family physicians, is the toll that this takes on the patient and their family.
Yeah.
Their families end up actually being the ones who have to make difficult decisions about whether or not they can continue being really the support in every single wraparound way.
Yeah.
And when we look at addiction and substance use disorder and the need for really that wraparound care that we have, it falls ultimately, because of priorities in government as well as healthcare, to family members and caregivers. Right?
And I guess it's a fine line too, because if you're a family member, you also don't want to be enabling the substance use. But it's really hard to make that distinction between supporting somebody and kind of keeping them going until they're able to be at the stage where they're amenable to treatment. And enabling, which is often viewed in a really negative light.
And part of my challenge as a family doctor, especially if I'm taking care of the patient as well as their family members, is those conversations that I have with the family members about, well, this isn't really enabling. You're just trying to get them to a stage, and really our support systems aren't there to support you and them.
Yeah.
And I mean, hold on hope, right? Like there's a lot of optimism that we try and impart, but it's not always successful.
Right.
Yeah.
You know, recently I learned about an emerging perspective that recognizes the deep connections between trauma and addiction. Initial ideas acknowledged that traumatic experiences, particularly in the younger formative years, can increase the risk of substance use disorder. And certainly this has played an important role in developing trauma-informed care approaches, which is moving in the right direction. However, new perspectives are attempting to delve deeper. Rather than acknowledging trauma, many people are advocating for the development of comprehensive treatment programs which integrate therapy that helps people process traumatic experiences. Studies show clear evidence that trauma and any type of addiction are connected. In fact, over 85% of people with any form of addiction have endured trauma in their lives, particularly in the early childhood or adolescence years, which are considered formative years. This is a particularly sensitive period of neurological development where the brain has a significant capacity to rapidly learn. This period of so-called neuroplasticity can be positive and support a person's overall development, but it can also be negative and establish neural pathways that underpin dysfunctional or harmful behaviors and impair coping mechanisms.
most likely this is referring to adverse childhood experiences, or ACEs, it's commonly known as. These are potentially traumatic events that occur in childhood with far-reaching consequences to a person's overall development and well-being. These include experiencing violence, abuse, or neglect, witnessing violence, household with substance use disorder, and mental health disorders, instability due to parental separation. An article in CMAJ Open, so the Canadian Medical Association Journal, in 2021 estimates that over 61% of reported exposure in the patient population of about ages 45 to 84 of at least one ACE, exposure to physical abuse, intimate partner violence, and emotional abuse were the most prevalent types of ACEs. Individuals younger than 65, so that's born in 1950 to 1969, with no post-secondary education or education below a bachelor's degree, or with annual household income less than $20,000, reported greater exposure to ACEs. And there's higher reports of ACEs among women and those of non-heterosexual orientation. Overall, Alberta, among other provinces, report relatively higher prevalence for several examined categories of ACEs. And so with this knowledge, with this sheer majority number that we have in our population, it's shocking that we don't actually address this in some way, shape, or form in our clinical settings, because there are ways to address this.
So there's definitely a lot of data around the prevalence of these adverse childhood events, and specifically as it pertains to trauma and addiction. There's an evolving understanding of the link between trauma and addiction that's inspired the development of treatment approaches that are designed to address both together. The critical paradigm is that trauma drives the addiction process from a neurobiological perspective. In certain case studies, such as in the context of PTSD or post-traumatic stress disorder, when the PTSD-related symptoms are decreased, the issues related to substance use disorder are also attenuated. But it's interesting, the reverse is rarely observed, where the initial attenuation of substance use disorder issues leads to a reduction in PTSD-related symptoms. This reinforces trauma as a critical driving factor in substance use disorder. And speaking to the point of ACEs, can you imagine the power of not only being able to identify these early in a person's lifespan, but to effectively intervene such that we can reduce the risk of somebody developing a substance use disorder, maybe in adolescence or later on in their life to begin with.
Correct.
Yeah. So as an aside, we can also be mindful that trauma doesn't necessarily have to be way far out of the ordinary to induce a significant degree of suffering in an individual and increase the risk for developing substance use disorder. Trauma can occur in the form of parents that are not attentive to one's needs, or experiencing bullying at school that surprised me, bereavement, serious illness, natural disaster, or witnessing violence in the home or community. Experiencing even one of these can possibly be traumatic for an individual and might even double the risk of developing a substance use disorder.
From a scientific perspective, investigators are interested in probing the neurobiological links between trauma and addiction. A key commonality is that both inputs to the brain alter the function of the reward system. The reward system of the brain is intended to be protective and supportive of life because it motivates us to seek the things we need to survive as individuals, as well as factors that promote the survival of the species, namely the drive to seek food, water, sex, and safety. An example of how this works is to consider the actions of key neurotransmitters in the brain. Dopamine motivates us to find sources of pleasure that support survival, reproduction, and help us to avoid threats to our safety. Dopamine acts on parts of the brain, such as the striatum and the prefrontal cortex, both the forebrain, to motivate us to seek more pleasure or to find ways to eliminate or avoid pain.
Another example is the release of endogenous opioids when we're stressed. When we encounter a stressful situation, a protective stress response is activated, which has evolved to help us cope with the stressor and eventually resolve it while remaining healthy. Part of the stress response is the release of beta endorphin, which is an opioid that our body naturally makes. The beauty of this response is that the action of this endogenous opioid in the brain and sometimes the body can help us to manage any pain during the bout of stress, like if we sustained an injury, for example. So that helps us to cope so that we can eventually get to safety and preserve our life. Sometimes this can be challenging to understand given the complexity of humans, so it can be useful to think about this from the perspective of a prey species trying to escape from a predator. Suppose during this stressful event, the prey species sustains an injury. This endogenous opioid release can help that subject cope in the moment until they can escape to safety and recover. The interesting thing is that humans have the mental capacity to generate stress in our own minds, and it's fascinating but also worrying that even an imaginary or perceived threat can activate the very same biological mechanisms.
And when a person experiences trauma, particularly in the younger formative years, the neural pathway of the stress response, as well as associated neurotransmitters and hormones, become disrupted. This can induce changes in critical areas of the brain, such as the amygdala. The amygdala has important roles in the processing of emotions, particularly during stress states. The nucleus accumbens can also be altered in response to traumatic experiences. Normally, the nucleus accumbens is important in driving our motivation to take action. In the case of early life stress, the nucleus accumbens may drive us to seek more of what makes us feel good and can contribute to the development of different types of addictions. Finally, the hippocampus, a part of which is crucial for supporting learning and memory, is also shaped by trauma. In some cases, some memories are diminished while others are amplified.
Altogether, the reward and stress systems in the brain become hypersensitive in determining what signifies a threat or stressor. A person's perceptions may be altered, such that something that would generally be perceived as non-threatening would represent a significant stressor or danger to them. At the same time, motivation to eliminate the threat, reduce pain in an effort to preserve survival is heightened. Over time, this can be manifested as impaired impulse control with less regulation by the prefrontal cortex of the brain and more emphasis on rapid reflex responses without careful reasoning or attention to potential consequences. It's difficult to make generalizations, but we can begin to understand why an individual might be intently focused on obtaining and administering a drug to achieve some relief from their psychological or physical pain, even if that results in consequences that are detrimental in the long term. Drugs that produce a calming and pleasurable effect become more addictive over time, and the altered function of reward pathways in the brain makes the cycle challenging to interrupt. Likely, this is because they, at least temporarily, produce a sense of well-being that's otherwise lacking.
From a biological perspective, it appears that these changes in brain function and behavior persist long after the traumatic event has passed, even persisting throughout the lifespan of the individual. The lasting impact of our life experience is why trauma-informed approaches have such potential. In the context of substance use disorder, since drug cravings are fueled by stress, treatment strategies that support people in developing better emotional regulation can help to address the stressful traumatic experiences and the addictive process at the same time. One approach is to ask a patient to revisit their traumatic experiences in a repeated fashion in a safe and controlled environment. But that's key, safe and controlled environment. The purpose is to help them process stressful emotions and empower them to recognize triggers. This could be in the form of environments and experiences that a person can learn to avoid to improve their journey to recovery. The aim is to eventually reduce the intensity or power of these traumatic experiences. In doing so, the stressful trigger is diminished, hopefully alleviating psychological pain, discomfort, and the drive to seek and use substances. The beauty of addressing trauma and helping people process it in a safe environment is that we can remove one of the most debilitating aspects of trauma, which is a feeling of helplessness. Processing the trauma removes the power and returns a sense of control to a person, which can help foster security and well-being. This treatment approach is absolutely dependent upon an interdisciplinary approach. And I would say a psychologist can probably be one of the best people to process and assist a patient in processing their past trauma. And especially if they aren't in the midst of dealing with current stressors, such as worrying about what their next meal will come from or where they'll even sleep at night. But it's more than just a psychologist.
Yeah.
What I would have to say in primary care that we almost default to is therapy. And the problem with that is two main issues. One is therapy therapy isn't covered for most patients or most people, right? Not everyone actually has a drug plan or a coverage plan for it. And secondly, finding the right type of therapy is always going to be challenging. The way that we've been taught is to look at CBT or cognitive behavioral therapy as this catch-all when, I mean, far from it. And CBT has its benefits, but it also has a lot of pitfalls. There are other types of therapies that are specifically geared towards substance use disorder. CBT or cognitive processing therapy, EMDR is another great example. But even engaging in those therapies is going to be a challenge for patients who anyways have distrust of our healthcare system, right? So trying to engage with them to even start this, even if it's available, is another thing completely. What I think is very, very important for us is to ensure that we're actually screening patients as early as possible for some of these adverse childhood events and I'll experiences. I'll give you a great example. I have 2 patients right now where we've been struggling for the last, I would say, 3 or 4 years to try to really get down to some of their chronic pain issues. And it's fascinating because one of my residents who recently graduated and that has an interest in mental health actually sat with our behavioral health consultant who's kind of like a mini psychologist, not exactly, but has some of those skills. And they come from our primary care network, and they actually sat down with these 2 patients. I'm going to be fully transparent that I would say that there was a certain amount of bias and I'd have to say countertransference that was developing for me with these patients, even though that's something that I really try to work against. And it really prevented me from really getting down deep to the traumas. Turns out there's a lot of ACEs that's sitting there. And I almost came up with this idea when I was there, and I said, this would be great, is that all our complex chronic disease management patients, we should actually screen them for ACEs, not just substance use disorders, right? But chronic diseases as well. There's a link likely there as well. There is a link between ACEs and chronic diseases. So it's not just substance disorder and addictions, because once we put it in that category and trauma, then we kind of just sort of relegate it to that, and bias can potentially get worse. When we think about the general population and chronic diseases in general, which substance use disorder should be considered in that. It should be not just be considered as addiction. It is a chronic disease. And so it's why a team of professionals is essential. And so social workers to deal with the current stressors, physicians, community and family members all play a critical role in supporting a person to address trauma and begin recovery and enter into a remission from substance use disorder. Even pharmacists, right? Who are dispensing the medications that are going to be used to treat their substance use disorder need to be on board with the entire plan and really be engaged with the patient.
So maybe we can say it's important for us to consider ACEs with respect to long-term health.
In general.
Yes. In general. Including everything from cardiovascular disease to metabolic disease, obesity, substance use disorder, everything.
And you talk about the physiological ramifications of stress, right? We talk about that in one of our stories of the week. And a lot of what you've been talking about in your physiology lectures ultimately stems from that.
Absolutely. Right? The long-term effects of chronic activation of this supposed to be protective stress response.
Right.
And the long-term effects of sympathetic nervous system activation, cortisol, all things that are supposed to be helpful for us, but unfortunately can start to work against us when they're provoked chronically, which is something that's somewhat unique to humans. Because most species, you either cope with the stressor or you're dead.
Right. And I think that's probably why evolution has made this a big challenge for us. Because we still have to live with these burdens.
Exactly. And we can be in bed, cozy, safe, 3 o'clock in the morning. Your eyes pop open. What are you thinking about? That time you got scolded in grade 4. And it just creates this visceral reaction. It evokes this stress response, which is something which is unique to humans. We have the mental capacity for that.
Absolutely.
And so we have to be mindful of how to manage that properly, for sure. Well, this topic can be uncomfortable on multiple levels, but there's value in understanding the complex connections between trauma and substance use disorder. This is also particularly timely with our upcoming discussions of harm reduction and care of a person that's experiencing overdose.
So if this discussion has caused some pause for reflection or brought up certain feelings or emotions that you haven't grappled with yet, we encourage you to reach out to us or the Office of Advocacy and Wellbeing in the Faculty of Medicine and Dentistry to discuss this further. We actually stand to gain from looking within before we look at treating our patients in the outside world.
Absolutely. Thank you, everyone, for joining us for this special feature on Real Doctors, Real Friends. We look forward to connecting with you in the next episode. Until then, take care of yourselves.
Bye, everyone.